Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
Our topic today is distalizing maxillary molars, and I'm pleased to have Bob Wilson, an orthodontist from Tufts University and also in private practice in Winchester, Massachusetts, here today to discuss this topic. Bob, thank you for coming.
Well, thank you for asking me, Jim.
Dr. Wilson and his father are really the developers of the distalizing arch that has been available for about 15 or so years, and I'd like to talk today about the hands-on management of this appliance. Can you give me a little bit of background as to how this came about?
Well, for a number of years, many orthodontists have expressed the need and desire for distalizing maxillary molars. With some different mechanisms that were used, the difficulty or problems were involved with the tipping of the teeth, the extrusion of the maxillary molars, which were both undesirable. And we developed the system to maximize the distalization, but minimize the tipping of the molars, to minimize the extrusion of the maxillary molars, and also to make sure that the roots were distalized. You know, most important, the roots were distalized, and this, in effect, would allow for great stability and without the problems of relapse, which other systems were having problems doing.
Okay, now, you want to use the diagram and sort of point out the different parts of the appliance and how it is used?
Okay. A 3D maxillary biometric distalizing arch is a complete arch form, which the anterior portion of the wire is an 022 round wire. The posterior section here is an 040 round wire. It has a class 2 hook in approximately the canine region. It has a stop, an adjustable stop that's crimped on to the distal portion of the 040 wire. The distal portion of the stop can slide up and down the base wire here to make adjustments in arch length. The reason why we call it a biometric distalizing arch is the two arch wire sizes. The anterior portion of the wire is designed as an overlay arch, and its prime reason for being there is just to hold the posterior section into the mouth. We prefer actually now to place this just gingival to the brackets. By placing the anterior portion gingival to your brackets allows you to use your bracket slots for your normal treatment. Our whole system is designed to be used in conjunction with whatever appliance system one presently uses. So no major changes in brackets or bands or arch sizes or bracket sizes or angulations necessary. The system is set up so that the distal portion of the biometric distalizing arch is inserted and passes through the headgear tube. And so we're really borrowing your headgear tube and using it temporarily for our distalization, and then later on in treatment can be used if you desire to use a headgear at a later point. The system is set up so this 040 wire slides friction-free through this headgear tube to minimize any moments of friction, counter moments and friction factors. The system is designed to be placed on the maxillary 6-year molar, and the pressure, the distalizing pressure is placed on the maxillary 1st molar, and the 2nd molar is pushed back along through the medullary trough. So it is not necessary to distalize the 2nd molar and then come back and, as a second procedure, have to distalize the 1st molar. They can be both distalized at the same time.
In an adult patient, is there any advantage to having the 3rd molars extracted, or is that a problem?
In the adults, one has to analyze the amount of tuberosity. If one has 2 millimeters of tuberosity present, you're not going to distalize 3 millimeters. The presence of a third molar actually is a good sign because it means there's more bone, more tuberosity. In the adults, I set this mechanism, place the appliances on the patient, get everything ready to go and ready to be activated, and then I take the third molars out. And then as the day the third molars are removed, then they start wearing the elastics in the system. And again, the best thing is to work in a fresh extraction site, the minimal resistance. The mistake that some people have made in the past is they've extracted the third molars and waited 6 or 9 months or a year, and then found out now you're working in a filled-in area.
Sure.
So,
Now, it's my understanding that from having used these, that these arches come in several sizes. Is that, do you want to talk about that a little bit?
they come in seven different sizes, and as one increases the size, the total length of the wire increases, but also the intercanine distance increases. And we've found that within the 7 sizes, it pretty much accommodates most everybody we've been able to treat.
Mm-hmm. Now, you want to talk about exactly how you fabricate these appliances, how you fit them, and also how you make the adjustments.
Okay. We've developed a measurer for measuring it so you can determine which of the 7 sizes are the proper size for your distalizing arch. And we measure on the model from the middle of the mesial cusp of the first molar round to the middle of the mesial cusp, which approximates the position of the mesial portion of the headgear tube. And so when we measure, you can measure around and it comes out with the approximate size.
Now, what's that size on that one?
This comes out with size 4, about size 4. There will be a variation if one selects the size between numbers. Obviously, there's about a 3 millimeter difference. Some of the reasons for choosing a one size versus the other size, up or down, is determined by the amount of discrepancy or crowding in the interior, which would tend to use some arch length on bending the wire. And also, if one does not have a gingival headgear tube.
As you do there.
As we do here. Many orthodontists have an occlusal headgear tube, which necessitates a step, a compensating step in the wire, as I'll demonstrate on this diagram over here. Okay. So as the diagram shows here, we've made a compensating step down to the occlusal headgear tube. This will be approximately 2 to 3 millimeters, depending upon the position of your headgear tube. The anterior portion, again, we suggest the easiest and the best place to put this anterior portion is to the gingival of your anterior brackets.
Now, you can also have a sectional or some other type of support in the front, is that right? You could have like a rectangular wire, blue alloy or something of that sort, soft wire that would fit into the brackets.
Yes, you can, as long as the incisors are relatively lined up. If the anterior teeth are very crowded, one would have to, in lining the crowded anteriors, would have to have some anterior component of force which would bring them forward. And so it's not desirable to line very crowded incisors up initially. But if they are fairly well aligned and there's space, then one can place a sectional wire through the 4 incisors to align them and stabilize them as one feels necessary.
So what's next?
Okay. Once you've selected the arch wire, I would suggest taking the arch wire that you've selected and placing it on your study model to just check to find out if it's approximately the right size that you want. The steps here for fabricating this wire we've developed to minimize the amount of wire bending necessary and also to minimize the amount of time it takes to adjust these wires.
Do you need to prepare the molars prior to the time of the insertion of this wire? Let's say they're severely rotated.
If you have a severe mesial rotation of the maxillary molars, one needs to first rotate the molars to align the buccal tubes up so they align with the buccal quadrant. There's two ways of doing this. First is using a parallel arch to rotate the molars, or secondly, one can use a buccal overlay wire where I take an 0-8 round wire, place a horizontal helix in the just mesial to the molar, and by towing that 0-8 wire in one side or bilaterally, one can rotate the molars in usually about a month to line them up, which also gives you some class 2 correction also.
Right.
The distalizing arch then is adapted, the anterior portion is adapted to the malocclusion, and is one of the few times in orthodonx you have to bend wires to make them crooked instead of straight. And we do this to make it so it fits passively above the brackets without any pressure. The second concern that we have here is the angulation of your molar tubes. If you have angulation, which these have about a 6-degree offset, very minimal adjustments have to be made in the posterior region. If they have no angulation, one would have to toe this posterior section in slightly. There are two nevers in bending this wire. The first being that you never bend the wire distal to your stop in this region. It will cause binding in the headgear tube. The second never is never bend right where the 022 wire and the 040 wire meet, because you'll get wire fatigue.
Are those made out of one piece of wire just milled to different sizes, or is it two soldered together, do you know?
It's the anterior portion here, the 022 fits through a sleeve that actually runs all the way through the distal portion.
Okay.
And so it's just a sleeve that fits on top. So, in making our adaptation for the molar rotation, if it's necessary, we do both sides, initially, and we can make a slight toe in.
Now, where are you putting the plier?
By holding in the middle of where the omega stop is,
Okay.
but not distal. Okay, you can do this in front, but again, not distal. Okay, and so in one's own practice, one would know automatically if one would have to do this offset. It just would be kind of automatic routine. We then place the wire on the patient's study model. And with a marking pencil, a red marking pencil, we mark the midline and then would mark the interproximal areas between the centrals and laterals and canine, and on both sides. And at these marks is where we would make our compensating bends, or our step-ins or step-outs, or begin our canine offsets. Then, by observing or looking at one's own study model, one can make their adjustments, their in and outs.
So that should be bent passively to the existing malocclusion in the front.
It's supposed to be made to fit as passively as possible. It's not always necessary that you tie into all four incisors, but we try to tie to as many as possible.
Okay.
The bends on the anterior then are made by holding the wire at your marks and making your appropriate ins and outs or whatever. When we get around to the canine region, we hold on the mark we made in the interproximal area between the lateral and the canine, and we make our appropriate canine offset.
Now, how big is that offset?
The offset is determined by the presence and position of the maxillary canine. Sometimes we have to we can make small ones, sometimes we have to make very, very large ones. I'm going to use this wire here. And so sometimes you may have to make a very large offset, which we begin in the 022 wire. The anterior portion and the distal portion then can be bent also to complete that curve. Okay.
So then what you did then in summary is you do the molars first to get the molars in proper position. Then you contour the anteriors.
To the 4 incisors.
Right. And then you put in your cuspid offsets.
And the canine offsets.
Okay. Are there any other adjustments that you need to make on the wire?
Okay, so I'm going to do the other one. Occasionally, you may have to make slight step ups or step downs depending upon the position of the centrals or laterals. And again, I make those steps right at that interproximal areas at my marks. So, once I have done that, I place it back on the patient's study model to see if those ins and outs and canine offsets have been properly placed. And the posterior regions should be adjusted so that they are about a millimeter wider than your buccal tube.
So what's the reason for that?
The reason being is that as one continues to distalize the maxillary molars, we want to make sure we don't constrict them, but continue to have a slight distalization, a slight widening, which follows the medullary trough.
Now, I assume then by saying the widening that you would, if you had used a transpalatal arch to begin with, you would take it out prior to the time of putting on the distalizing arch. That's correct.
Any palatal appliances should be removed when you're using this mechanism to distalize. The palatal appliances tend to stabilize and hold the molars in position, and that is contraindicated.
Okay.
Once the wire appears to be symmetrical and passive laid on your study model, we then take it to the patient's mouth and do some fine tuning to make the wire so it fits passively. I always tell the patient they're going to open and close about 10 times, and so they don't get frustrated, and I don't get frustrated.
You meaning you take the wire in and out each time?
Yes,
Yeah, okay.
to make adjustments. All adjustments are made outside the mouth. The first thing I do is place the wire above the brackets and not insert the posterior portions into the headgear tubes. And the first thing I want to do is see if my ins and outs, my adjustments in the 4 incisors are correct. I would then check my canine offsets to see if the canine offsets are proper. And then the last thing I do is insert the wire on one side into the headgear tubes and to see if my molar rotation and position is correct. And you may have to make fine adjustments to make sure it lays passively. And final adjustments for this molar rotation and canine offsets, when one puts the one side in, inserts it in the headgear tube, we adjust the anterior portion so it comes back and lays passively above the brackets. And so in this case, you may have to make some slight adjustments to increase or change the canine offsets.
Now, are you making a vertical adjustment in that with that bend?
Normally, one doesn't have to make vertical adjustments. In this model, since it's already leveled, the incisors are the proper level, on the model here, I'm going to have to make just a slight step up to make sure that the wire just goes across the gingival portion of the bracket. So I put about a 0.5 millimeter step. In bending these wires, one should always, after they do a few bends, to look at the wire and line the posterior sections of the wire, the stops, to make sure it's symmetrical. If it becomes very asymmetrical, something's not right. You've done too much wire bending.
How long does it take you in your office to put one of these in? From the time it comes out of the box to the time the patient walks out the door?
Usually less than 5 minutes. And the cases you do more wire bending would be like a Class 2 Division 2 type of case.
Mm-hmm.
But after you do a few of those, it becomes very logical. You just make a large step into the centrals. So in actuality, they really don't take that much longer either. Probably what would take the longest is if you have a blocked out maxillary canine that is way buccal, and you may have to make that large offset, which I said, which takes just a little bit more time. So we insert the posterior section on one side and adjust the anterior portion so it lays passive. And then we remove the wire, place the opposite side posterior section in, and adjust it so again the wire comes back and lays passive. If the wire is properly designed, the wire should not touch the bicuspids in the bicuspid region. It should be at least 1 millimeter away from the bicuspids.
Does that give you somewhat of a lip bumper buckle shield kind of an effect?
It gives you a slight buckle shield effect. It does keep the cheeks away. And, you know, the 1 to 2 millimeters is fine. If you put it much more than that, it may irritate the cheeks. So.
Do patients ever complain of the hooks, the Class 2 hooks, ever being bothersome?
If the wire is placed gingival to the brackets, it is minimal, discomfort or problems. Some doctors have placed it gingival to the brackets, and then the Class 2 hooks tend to be in the way of function and eating and things like that.
You mean occlusal to the brackets?
Yeah, occlusal to the brackets, yeah. The Class 2 hooks also can be rolled in if they are sticking out a little bit far into the cheek or whatever, and they can be rolled in a little bit. So,
now, what you've done so far is basically to make this passive, is that right, at this point?
yeah, the
With
wire,
the exception of the slight bit of widening?
the initial design is to make it completely passive. And no attempt has been made, or initially is made, to change arch form or alignment of teeth.
Mm-hmm. Now, where from here?
Okay. In the patient, once it's passive like this, we check the position of the stop in the posterior region to make sure it's flush against the headgear tube on the right and left. And also, the omega stop here should be placed so it's about 1 millimeter away from the tissue. And so you don't want to impinge upon the gingival tissue, nor do you want it into the vestibule, way out in the vestibule, which this one is. And by holding the stop, you can roll those in just slightly. Okay. So at this point, we have a stopped arch wire, bilaterally stopped on the molars. It's essentially passive, or as close to passive as possible. And essentially that is the end of the first visit with this arch wire. No coil springs, no elastic, no distalizing force initiated at the first visit.
So that what you're doing is you're allowing the patient just to get used to wearing the appliance.
So they get used to having these wires in their mouth without any great discomfort.
Okay. Now, one thing that I've noticed in having used these for many years is that it's very important to warn the patient that there's something sticking out of the tube in the back,
Yes.
as opposed to letting the patient leave the office, because we always stress the idea of check the wires for length. And when you do this, do you tell the patients that there's something new in there that they've never had before? How do you handle that?
With the extension portion of the wire here, we always advise the patient there is some excess wire extending distal to the headgear tube. And the reason we normally will leave that wire is that we need that as we move the molars distal to maintain itself in the headgear tube. We find that this 040 wire tends to not irritate very often. I feel there's an advantage with a gingival headgear tube tends to cause less irritation also. The patient which it tends to be a problem in is the very young patient, which doesn't have a very great vestibule height and development in this area. If this portion of the wire does irritate, my suggestion is when the patient comes back to remove maybe half of that extends, not all of it. Mm-hmm. And my experience has been only one side.
Really?
Not both sides.
Okay.
So. Okay.
Now, you've sent the patient away with a passive arch. How long before the next appointment?
It can be a week, 2, 3, 4, whatever, works best for your scheduling.
Okay. Now, at this next appointment, I assume that you are going to put on 1 or 2 coil springs, depending upon whether you want to distalize 1 or 2 molars. And you're going to be putting on elastics. Do you want to maybe use the diagram and explain exactly how the elastics are used?
When the patient leaves, the wire is tied in with a steel ligature, and so that the wire doesn't fall out. And we try to tie to as many of the anterior brackets as possible. When the patient returns for the next visit, we're going to remove the arch wire, and the stop is closed by taking a optical plier or an omega plier and closing the stop. And that closure here will be about 3 millimeters. And so now if it was placed back in the mouth, you'd see 3 millimeters of space. We then apply or place our 5 millimeters of coil spring.
Now, this is just stainless steel?
It's just stainless steel. And it's important that we use just the 5 millimeters of coil spring. If one's constantly varying the length of coil spring, then one doesn't know exactly how much force to use on the class 2 elastics.
How much force is generated with a compressed spring like that, do you know?
Approximately 6 ounces of force.
Okay.
Obviously will vary, greatly, but the amount of elastic force we're going to use is approximately 6 ounces. When the coil spring is placed in the mouth, on the wire, it's friction-free. When we place it back into the mouth, if the wire anteriorly is placed against the incisor teeth, then there will be a compression of the coil spring of 2 millimeters. And my recommendation is that the orthodontist does not tie the wire back in at this point, but places the class 2 elastics on the hooks. And it goes from the mesial hook on the molar, which is very important, up to the class 2 hook. In our normal cases here, we, again, have the 6 ounces of force. If you put your 6 ounces of elastics on this side or both sides, the wire then should be held right against the anterior portion of the teeth.
It's my understanding that you have different regimens of elastic wear and sizes for different conditions. Is that right?
Yes, and we have what we call a set Schedule 1, Schedule 2. The Schedule 1 is for cases which have poor mandibular anchorage, where we're concerned about the lower incisor and their position, where we use a light elastic, which is a 2-ounce 5/16 elastic. And we go through a sequence of placing 3 2-ounce elastics to get a total of 6 ounces of force. They wear this for 5 days. The patient then wears only 2 of these 2-ounce elastics, which is a total of 4 for 5 days. And after the 10th day, wears 1 2-ounce elastic until the next visit.
And how long would you allow a patient to go without being seen? 3 weeks, 4 weeks max, or?
Normally, seeing them any more frequently than 3 weeks is not necessary. It can be 3, 4, 5, or 6 weeks, depending upon how your office runs. After about 3 weeks, you've got the maximum movement out of this, and any other further movement would be more functional changes or some more distalization with actually retraction of incisors. The Schedule 2, which is the most common and the one that we normally recommend, uses a 3-ounce 5/16 elastic. And this is for your Class 2 Division 2 cases, Class 2 Division 1s with the deep bites, cases with steep cusp, or adult cases. And here we wear 2 3-ounce elastics for a total of 10 days. And then they wear 1 3-ounce elastic until the next visit. There is a variation on this in adult cases. And normally in adults there is a delayed response with the osteoblastic activity, and normally you will not find a total of 1.5 millimeters or 2 millimeters to distalization the first month. It may be 0.5 millimeter, maybe 1 millimeter. And to prevent any possible advancement or flaring of the maxillary incisors, in the adults, normally the first month they wear 2 elastics for the whole first month. And it may actually go into a second month depending upon the movement of the distalization. In the adult cases that we're doing this in are usually deep bite cases and cases where steep cusp, and so the anchorage concerns of the lower arch are not as great. So I don't worry about the lower incisors as much. The other sequence or variation would be in extraction cases, where obviously the arch length is a little bit shorter, and instead of using a 5/16 elastic, we use a 1/4 inch.
What are the specific instructions that you give to a patient?
We instruct the patient that they wear these elastics 24 hours a day. They wear them when they sleep, when they go to school, and especially when they eat.
Why eating?
Because obviously the elastics are being worn and activated and stretched, and almost more important is that if they remove them to eat, especially a lot of young people just forget to put them back on when they finish eating, and so then it's another 6 hours, and they then remember 6 hours later at another meal.
Have there been any studies that have been done on patient compliance and whether there is an optimum amount of time?
A number of years ago at Munster University, the orthodontists there mentioned they had done a study with their patients having used this system, and they found that the average numbers of hours worn a day was about 20 hours, and that the whole system worked. My recommendation to them was still insist upon 24 hours.
Do you find a difference between, can you pick a patient who wears the appliance for 24 hours versus somebody who wears it 20? Is there a difference?
You can definitely see the difference. And it is quite remarkable. The patient makes tremendous progress. Also, if there have been any slight functional changes and reposition of mandibles, the 24-hour day wear is really important in those cases also.
Do you ever see spaces opening up anterior to the first molar, as of between the first molar and the second bicuspid?
In a growing child, a growing individual, normally you don't see very much space. The transeptal fibers are very strong between the second premolar and the molar. And we find that the second premolars will retract with those transeptal fibers on their own. The normal amount of space is basically would be the width of a dental floss, piece of dental floss. In the adults, it's different. You may see some significant space open up, and the reason being is the transeptal fibers and the force exerted by them is probably not enough to overcome the resistances from movement in the adult bone.
Now, there's one sort of final comment that I'd like to make, or one question, and then I want to sort of try to summarize all what we've talked about. Let us assume that we have succeeded in distalizing the molar as far as you want it to go. And I think that that's been shown to work out very nicely. What I have seen upon occasion is round tripping, where somebody will distalize the molar, get it back, and then by trying to retract other teeth, they'll lose anchorage. How do you avoid that both in an adolescent and an adult patient?
There's a couple ways. Number one, they can move to a headgear nights. Another way that we do is we put a paddle arch in for extra anchorage. In my office, I maintain a lingual, the distalizing arch, remove the coil springs and open the stops to make them flush against the molar tubes. And then I will retract the first bicuspids or canines as necessary and continue to wear class 2 elastics, the 2-1 sequence. I find that's very helpful in cases where I think there's been some type of functional repositioning. The longer you wear the class 2 elastics, the better. When it comes to retracting the upper anteriors, if the upper anteriors are flared, then I use our same 2-1 sequence with the elastics. I then shorten the stop about 1.5 millimeters to 2 millimeters per month and do the same 2-1 sequence, and we can roll the incisors back. If the incisors are upright at that point, then this is not the treatment of choice. Then I think you would have to use some type of rectangular mechanism and support the molars because you'll be pulling against the upper molars.
Okay.
So,
Are there any other comments or suggestions that you might have for someone who is using the arch? What have you found as far as your students at Tufts, the common mistakes that they make?
I think the suggestions are in wearing the elastics. Number one, that I encourage the patients to wear them the 24 hours a day, but change them twice a day, once in the morning when they brush their teeth, once at night. Then they don't tend to break as much during the middle of the day when they're at school. And I think probably the main difficulty here is making sure the patients wear the elastics. I tell, and my students will tell the patients that if they don't wear the elastics is the only time they should feel any sensitivity, any pain or discomfort. And that would come from a little irritation on the incisors, the upper incisors. And to minimize or negate that, they wear their elastics. So my students at Tufts have done some, very, very nice things with this. And it's a type of thing that in discussing with a patient is motivation. Whatever appliance one uses, one has to motivate the patient to cooperate. If it's from a Frankel appliance to simple edgewise or headgears or our mechanism. And I present this as a positive type of thing, that I would like to be able to treat a particular case non-extraction by making room on the upper arch if that's the case. And if we can, we don't have to extract some teeth. And we try to present the reasons for using this mechanism. I always present to them the fact that if they don't wear their elastics or they don't cooperate, there's other things that may have to, considerations may come into force.
Well, I remember any number of patients that have told me that the biggest reason why they've worn their elastics is that if they don't, they get spaces in their front teeth. And I think that that's probably more than almost anything, you're almost assured of patient cooperation, or it's not that nothing happens, it's that bad things happen, at least as far as the patient's concerned. Well, thank you very much. Is there anything else that you want to?
Yeah, I was going to say there, in that point, my experience with adults, and also the students in school with the adults, is the adults are very motivated to wear elastics. If they can avoid wearing headgears as much as possible, they're happy. And for them, I always tell them that those bicuspids, the back teeth where they've had difficulty flossing these last number of years, all of a sudden they're going to be able to floss quite well.
Right.
And so the motivation is very, very good there.
Anything else?
I can't think of anything right
Okay.
now. So.
Well, thank you very much. I really appreciate you spending the time with me today, and
Okay.
hopefully somebody listening to this will have a little bit better idea on how to use the Wilson distalizing mechanics. Thank you.
Okay. Thank you, Jim.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.